Welcome. We're going to talk about cancer in this session. They switched rooms on us, so if someone needs to get up and go to the other room, I'm not going to be offended. So, I'm Bill Petros, and I'm the interim director of the WVU Cancer Institute. Formerly, we were called the Mary Bob Randolph Cancer Center, so I just want to maybe formalize why we use two labels right now. So, as you know, WVU Medicine has recently expanded into multiple different clinical entities, and part of that is a cancer center expansion. And part of that expansion is we created an institute to envelop about 6 different clinical enterprises. But also, the Cancer Institute includes much more than just that. It includes, we have, as I said, these bigger enterprises, and our main mothership, as we call it, is the Mary Bob Randolph Cancer Center, shown in this slide here. So that's our main clinical facility in Morgantown, where we offer the plethora of services, in addition to these satellite sites, which offer a variety of services also. But the important part and why we're not just another cancer center, that we're a cancer institute and we're part of the university, is we do research and we do cancer prevention and control. And similar to what Dr. Sparrow talked about this morning, we have a number of faculty that are members of our Cancer Institute, over 120 or so faculty. And they have laboratories that span from the Health Science Center, all 5 schools of the Health Science Center, to engineering, to biochemistry, to biology downtown, chemistry, physics. So we have members that span the university, and really we take full advantage of that multidisciplinary nature to conduct our research. We also have a number of people that do cancer prevention and control activities, both in Morgantown, and they actually span across the state. So we do cancer prevention and control service and research across the state. And the final component, but an important component, is we provide education. And we have a graduate program in cancer cell biology, a PhD training program. We also train physicians to become oncologists and pharmacists to become pharmacy specialists in oncology. So there's a variety of different programs. Even in the summertime, we have undergraduate students coming into our labs to be able to learn research and see if that's what they want to do in life. So with that, let's talk a little bit about cancer in general, just to give you a snapshot, some of the problem we're dealing with. And then I'm going to talk about a specific area of cancer that we like to call precision cancer care. And we'll talk more about that, and intermixed in this, I'm going to give you examples of what types of research we're doing in the Cancer Center, specifically on precision cancer care. So with that, let's start with a little bit of statistics. And I'm going to limit it. I'm not going to show any live animals in my presentation. And I'll try not to show any gory slides or anything. So after lunch, we're not going to worry about that. So unfortunately, if we look around the room, 1 in 3 of us will get cancer sometimes in our lifespan, if we limit an average lifespan. So it is a very frightening idea that we start thinking about the statistics behind it. And in fact, if we look at the data now, as of 2014, cancer is the leading cause of death in 22 states. So soon to be encompassing in all states, and it will be the leading cause of death in the US. West Virginia is one of those 22 states where it is the leading cause of death already. And as you see, the darker the states are here, have the higher mortality rates of cancer. And in fact, in West Virginia, we do have a problem. We're number 2 in female mortality from cancer. We're number 7 in male mortality from cancer. So what are risk factors associated with cancers? Anyone? Potentially environmental factors. There's something more obvious, though, that's been real well tested. Smoking. So unfortunately, yes, we're number 1 in tobacco use. Yes. Kentucky and us kind of go back and forth on who's number 1, but unfortunately we are. Now, we'll talk about at the end, maybe a way to get around that. The most effective way is hopefully going to happen here real soon. What else are we number 1 in? Obesity. And in fact, the statistics have shown that obesity is probably going to overtake smoking as the number 1 preventable cause of cancer in the United States. So yes, we have a double hit here as far as risk factors. And another risk factor, which we can't do anything about, is age. And as we know, there's a steep incline in the incidence of cancer as we age. So people in kind of I'm right in that steep incline area. So in our state's average age is one of the oldest in the nation. It's actually older than Florida as far as the average age of population in our state. So we have that factor involved in the number of patients that are seen in West Virginia with cancer and the mortalities associated with it. Just a couple words about obesity-related cancers because there's not as much public information about this. A number of cancers have been associated with obesity, and this slide depicts some of those cancers that have been associated with obesity. Not every cancer, but some of the very important ones have been associated with obesity that are more common, like breast and colon cancer. And we'll talk a little bit more about obesity as we go through the talk here. So, precision medicine. So, what is this term? And there's not a real well-defined a good definition of the term, but this is one that at least the government likes to use, which is it is an approach that uses genomics and environmental factors and lifestyles to depict the disease prevention and treatments of how we're tailoring treatments specific for an individual. And so I'm going to talk about some examples of precision medicine as we go through the topics here, or through the talk here. Now, one of the things that I'd like to kind of dispel, and I tell this to the students, and I teach medical and pharmacy students occasionally, and one of the things that I said, if you go home this weekend, what's the first question your parents or friends are going to ask you? And they're going to say, what are you learning this week? What are you studying? And you tell them cancer. And what's going to come out of their mouth? What's the first question they're going to ask you? And again, I'm teaching pharmacology of cancer, so what do you think the people would ask? Prevent, cure, right? Or when's it going to be cured, right? And see, so that's, and the answer is, it has been for many cancers. So there's a lot of cancers that we have cures for, but there's a lot we don't have cures for. And this is where the precision medicine approach comes into effect, because we need better ways to define treatments so we can select them specific for the individual, for the type of cancer. To date, our cancers are categorized into where they started: breast cancer, prostate cancer, lung cancer. But we know the biology, even within, say, like breast cancer, there's multiple different types of breast cancer. And we're only beginning to understand how to best treat those types. And the genomic techniques that we have available now, and we've had available just recently in the last decade or so, has really pushed the envelope on helping us better understand those diseases. So we know that this breast cancer is curable, and this breast cancer we're going to have to be really aggressive and use other treatments for. I don't think there'll ever be one cure for cancer, is the bottom line. But there's already are some cures for cancer, and there's many more that I think we will be able to discover in the near future. So let's talk now traditionally on how things are typically done to diagnose someone with cancer, and this will lead us into new ways in the precision medicine approaches. So typically, a surgeon or an interventional radiologist here sticks a needle into someone, maybe after they've gotten a CT scan or while they're doing that, so they can see specifically where that tumor is and the biology of what that is. It might not be a tumor, it might be an infection, etc. So part of that tumor is going toward a diagnostic pathway. So we're going to try to figure out what's there. Is it a cancer or not? So what's typically done is a piece of that tumor is made into a slide. It's put under a microscope, and you put a variety of dyes again on the slide. And that tells, it allows you to look at what the tumor looks like, the cells in the tumor, and how similar or dissimilar they are, how many there are compared to the normal cells. And that tells a lot about if it's a cancer or not, and where the cancer might have come from. Say, like if you had a problem in their back and they stuck a needle in the back to look at a tumor, they might see that it actually came originally from their lung. And that might help us then treat the patient depending on what type of treatment to get. And so this has been done for decades now. This is the way we've diagnosed cancers, and we've looked at special different stains that looked at specific proteins that might tell us how to treat that patient. But it's not very sophisticated as far as drilling down into the things that cause the cancer. Now, the other thing that we actually do is part of that tissue, if there's enough of it, we retain for research purposes. Now, that's important to move our field forward. We have one of my colleagues, when he teaches medical students, he tells them, well, if you're happy with the treatment you have being given to patients now, and then don't do clinical research, because you'll be doing the same thing 10 years from now. If you're not, then we really need to move the field forward by doing clinical research. I'll try to move this down a little so we get echoes. So banking a piece of the tumor for research purposes is important, and our scientists use that all the time, and we'll talk about some examples of how they use it. But also it might benefit the individual patient later too. Now, you'll see little yellow stars as I go through my presentation here. And the yellow stars indicate these are areas that we're actually doing active research in that area. And we'll come back to those later. So our current understanding of cancer is that it is a genetic disease. Not necessarily an inherited genetic disease in many people, but a disease in which our genes are messed up. And so if we think about our genes, we can think of our normal genes. We have normal genes that control the growth of our cells. And if those normal genes are attacked by a virus, let's say, or a carcinogen, things we breathe in or eat, they can become damaged. And sometimes that damage doesn't get repaired. And so then that's the problem. The cell doesn't know it's damaged, and it continues to grow, and it continues to grow in areas adjacent to where it's supposed to be growing. It destroys normal tissues, et cetera. So it transforms itself into a cancer cell. So it's a specific genetic defect. Now, oftentimes the thought is that it's not just one genetic defect that occurs, because we're exposed to carcinogens every day. It probably needs at least a couple hits or a couple different genetic defects. Now, that's not to say that there is an inherited nature to some cancers. But I'm just to say most of the cancers we deal with, at least in the adult community, are not necessarily inherited from our parents. They're things that are happening more on a random basis. This is another way of kind of looking at it, because we are going to talk about it in a couple different ways. So we have a normal piece of DNA here that we get from our parents, and that's inheritable. And in the cancer world, we call these mutations that occur in cancer somatic mutations. So they've happened after we've been born. So in the normal tissues, we call that the germline cancer, and we can inherit this. And we have two good copies or two normal copies of the gene. And it's easy to get DNA from our normal genome. We can take a piece of hair, a piece of skin, some blood sample from our white blood cells. It's easy to access the DNA in our bodies because it's all the same wherever you take it. Tumor tissues are different, though. So the tumor, it's not necessarily heritable, not inherited for the most part, as I said. It can be heterogeneous. That means, like, if we take someone's lung cancer and it's a big lesion, and we stick a needle in different parts of it, we might get different mutations in the different parts we stick the needle in. Or if that's metastasized now to the liver, that might have a different mutation in it than the primary disease does. So it's a little difficult sometimes to deal with, and we're learning more and more about that heterogeneity. It's not a roadblock. We could still use the genetic information that comes from a biopsy, but it's not necessarily as clean as we would like it to be. Oftentimes, as I said, if this tumor occurred in our pancreas, it's kind of tough to get to that compared to the skin if it was melanoma, right? And the other aspect of these that's presented the challenges is that tumors are our normal DNA. Our normal DNA. Talk with my hands too much. Our normal DNA is stable. It's not going to change over our lifetime. Tumors change. It's part of their nature. So they can evolve into different mutations that maybe make them resistant to our treatments after we start treating them. So we're going to talk about precision medicine in the context of the individual for most of this talk. But there's another way of thinking about this too, and that's precision medicine in context of our whole population. So how cancer researchers usually develop new drugs and study the disease is they take these things called cell lines. And they've been grown over years and passed from one university to another, and you might have heard of the HeLa cell line, the Henrietta Lacks story. So this lady that was diagnosed with cancer many years ago, and we still use those kinds of cells. But so when we're developing a new drug, we take these cells that we've gotten out of freezers over the years and put them into a Petri dish and see if this new drug works. Hey, it works, fine. Then we put it into an animal and grow that tumor in an animal. It might work again. Problem is, when we take that kind of a cell line data and try to use the same drug in patients, it's not a very good reproducibility thing that predicts what's going to happen in patients. So we need better models. So probably about 10 years or so ago, people developed what's called patient-derived xenografts. Xenograft is when you take a mouse and you essentially make the mouse's immune system dampened so a tumor would grow in it. And you take a patient sample and you actually put it into the mouse. So here the surgeons are actually collecting a patient sample, and we're going to transfer that sample into this mouse. Now, why is this important for our state? Well, a tumor that comes from, say, New York City, a patient in New York City, might have a lot of different environmental factors that are associated with that tumor. And then think about, again, our triple hit of cancer: aged population, smoking, and obesity. All those factors can change the biology of the disease itself. And so when you're studying drugs and treatments and patient samples from New York City or Boston or something like that, it might be totally different than what we're seeing in patients from West Virginia. And again, as Dr. Gee said, we're trying to, one of our land grant missions is to help our patients specifically. And so some of our research is being done where we create these mouse models and we put them in, we put patient tumors directly into the mice, and then we grow the tumors in the mice, and then we test the drugs in those specific mice. So it more mimics our population. The important part about this is, there's cancer centers around us, but no one has the access to the tumors like we do from West Virginia patients. So there's not a whole lot of people that could do this type of research in our population. And so we're doing this for things like breast cancer now and starting efforts for lung cancer and head and neck cancers. Now, the nice thing about this is we can grow those tumors in multiple mice. Once they start growing in a mouse, we can pass it to another mouse and another mouse. So we could feed all of our researchers from a small piece of tumor. And they're pretty much immortal. We can continue to grow those. Okay, so now let's talk about precision medicine for the individual. This is one of my favorite pictures of the mountaineer standing on top of the rock there. That commercial was really cool, I thought. And, it epitomizes the individual. So the things that we are trying to accomplish with precision medicine for the individual are selecting out the right treatments first. Which drugs are going to work best for those tumors in that patient? What's the right dose of the drug to use and the right time to give it? And I'll give you examples of these as we go forward. So first, how do we deal with the right treatment? Well, we have a number of regimens that are well established. If a woman comes in with early breast cancer and needs treatment, we have some very efficacious regimens that are associated with treating that patient. However, the personalized or precision medicine approach can help tailor down that treatment a little bit further, even in regimens that are highly efficacious. And the example I'm going to use is lung cancer in the next slide after this one. So that's one way we can get at it, but that's not our biggest problem because, again, these are highly efficacious. They work well, the regimens here. We're just trying to refine them a little. Where we really need to this approach will help us the most are in regimens that are less effective. So our standard regimens that aren't as effective, we can then use this precision medicine approach to test the genetics of tumors to be able to select out which drugs might work the best, that we wouldn't have just guessed taking something off the shelf based on where that tumor started from, be it the breast, the lung, etc. And finally, in very advanced cancers, let's say a patient has already been treated and now their cancer has relapsed. And so sometimes all bets are off in that kind of a setting. There's so many mutations potentially that have developed, we really have a hard time selecting, and oftentimes it's a guessing game. You might have to select from 6 different regimens, and you don't know which one. So you take one and you see how the patient does, and if they don't do well, after a few months, you have to change regimens. So we'll talk a little bit about the examples here. Oh, and of course, a number of the clinical trials that we do now for brand new drugs have new targets. They haven't been studied before. And so we have patients that their cancers seem to be growing based on those specific targets. They're feeding the cancer. And so when we find a new drug, we can actually then say, oh, this patient is eligible for being treated with that new drug because they have this mutation in their cancer that is driving their cancer. And this drug targets that specific mutation. So that's where it's getting the most press right now. But we are using this from the clinic and routine clinical care in some patients all the way down to clinical trials for investigational drugs. And we'll talk a little bit more about that. So probably the area that in the solid tumors anyway where this has been most actively applied is lung cancer. And it used to be when lung cancer was treated, we treated it as kind of one disease. We didn't know that, we knew it was lung cancer by looking at the stains and how the cells looked and where it came from, but we didn't know the biology of the cancer in that individual. And so over the last decade or so, and this changes by the month it seems, we've come to understand that over half of those cancers, what the driving forces were. So they had specific mutations in these genes that are all kind of labeled here. And so now when a patient comes in with lung cancer, they're actually tested for a number of those genes, the ones that we have drugs for at least, and we can tell then what drugs to use. So the example I'm going to use in the next slide is EGFR. So it's called the epidermal growth factor receptor. So patients that have this mutation in this particular gene, we have drugs for to treat those patients. And so this is an example of the complex algorithm that people use to treat patients with lung cancer specifically in this example. So this is patients with non-small cell lung cancer, and this tells them, okay, they have metastatic disease. This means it's spread beyond the lungs, and physicians then follow these algorithms for how to treat that patient. And you'll notice out here, if you go all the way out here, this is patients with EGFR mutations, and then that tells us here's the drugs to be able to use in those specific patients. So we're doing genetics of the tumor to be able to sort them out if they have EGFR mutations or ALK mutations, or there's some another ones you can add to the list now. Now, sometimes we're getting to the point where there's a lot of these mutations that have been identified, and we probably want to know more about ones that if a patient's just tested for those mutations and they're negative, we'll have nothing to offer but standard treatment. But there might be experimental treatments out there or drugs that we really didn't think about because they haven't been active in more than a few percent of the lung cancer population. And so a number of situations, we're actually doing what's called full genome sequencing now. Or it's actually not full genome, but it's looking at hundreds of different mutations in the cancers. And so there's some commercial companies that do this now. This is just a report from one of those commercial companies, or an example of a report from one of these. And so they're testing hundreds of genes in that patient's cancer, and then it tells you whether or not the drugs, if the patient has this genetic defect, what drugs might be applicable to treat them with. And then what drugs that with potentially lack a benefit and that you wouldn't want to give them that treatment, even if you were thinking along those lines, and ones in which kind of it's in between. This is a very evolving field right now, and the recommendations for a patient's tumor might change by the month with new drugs coming on and with new ways to identify these mutations or the implications of them. So there's actually a nice website that you can kind of plug in a gene and actually find out what the implications are. And this website also used to be able to find clinical trials on it too. It would tell you, oh, you have this ALK-positive mutation, and it's one in which our standard drugs don't work. Here are clinical trials that are available across the country to be able to, perhaps you might be eligible for. Right now, I'm not sure this part wasn't working last week. So I'm not sure if it's a permanent problem or they're going to fix it or not. But this is just one example. But what this reminds me to tell you about is where we're going in the future is not necessarily when, I think one of the talks this morning talked about, like he asked, I think George Spiro asked if anyone had their genome sequenced, the 23andMe kind of thing. And where we're going in the future is not necessarily, you can sequence someone's genome and have a list of the genes and variations with it. That's not a problem. What we really don't know about is the implication of that. And what if a new drug comes on the market and you have to alter the dose if you have that particular, or if you're taking that particular drug? Well, if you had your sequence done a year ago, that's not going to be in your report, right? So I think where the future is going with a lot of this is someone's going to we need better refinement of these websites where we can take our genomic profiles that we're all going to be carrying in our pocket probably in the next 10 years or so and be able to plug them into a computer and say, okay, now how does this apply currently? So I think of it as it's like when you go to the pharmacy and the pharmacist looks at your profile and screens you for drug interactions and things, you're going to be screening for genomic interactions kind of at the same time down the road. So it's nice to know your genome, but how it's applied today is going to be different when you walk in the pharmacy 10 years from now, and you might need a different answer to that. Okay, so we talked about these nice drugs that target these specific genetic defects. And they can produce dramatic changes in patients without a whole lot of toxicity compared to some of our old drugs. So this is actually one of those drugs. This is a patient, I'm sorry for showing this after lunch, but it drives home an important point to consider. This is a patient with melanoma, skin cancer, of course. And we see that he has multiple lesions on his skin. He received an oral drug, and usually, traditionally, this would be treated with very toxic IV drugs. Received an oral drug, and 3 months later, voila, look, it's incredible, incredible response. Unfortunately, this is 6 months later. So the tumor now has mutated. So it's genetically changed and found a pathway around that drug. Now the nice thing is, if you biopsy that today, the type of mutation that's there would actually be responsive to a new drug, an even newer drug that's come out. So we're chasing the tumor now, and we're just learning on how the tumors are getting around resistance to these oral drugs. And that leads us into one of our laboratories that I'll highlight here. This is a laboratory of Dr. Patrick Ma, who's a physician scientist in our cancer center. We recruited from Cleveland Clinic a year or two ago. And Dr. Ma, he's a lung cancer specialist, and he studies the genomics of lung cancer. And specifically, he's looking at how these tumors, once they're treated and they do well, then tend to recur in many cases, and what is pushing that recurrence, and how we can better use our treatments to prevent that from happening or detect it earlier. So this slide's going to show you some of the techniques that he's using to do that. So one of the techniques, as I said, most of the time we're dealing with pieces of tumor, but the kind of the next wave that we're going to see in probably the next 5 years or so is even with patients with solid tumors, we're going to be looking at that in their bloodstream, not necessarily sticking a needle in them. There's emerging data in a number of cancers now that if patients that you can see circulating tumor cells or circulating pieces of DNA from that tumor in the blood. So it's a lot easier. We call this liquid biopsies instead of a solid tumor biopsy. And so he's studying partly that phenomenon. And that was another reason why when I went back to that slide and I said we take some tumors and we put them in the tumor bank for research purposes, we're also collecting blood in those same patients to see if we could see it in the blood for research purposes. So what Dr. Ma's lab has a cell isolation instrument that they're able to take tumor cells out of blood or ground up tissue, and they could isolate those cells into single cells. And so you've now pushed them into this mix of single cells, and then you could put them into this new instrument that they just got in the last few months that allows the single cells now to be studied, to be sorted into one little channel here. And that little channel then gets hooked up to an instrument that can measure the DNA and RNA in that single cell and that produce a colorful things like this. It tells us how the different genes are interacting. So we're at the point where we can look at the DNA and RNA from single cells from either blood or ground-up tumor, which really tells us a whole lot, or will help us a whole lot about understanding resistance from the beginning to what's happening in a patient as they are under treatment. So another way that we're using precision medicine is to identify patients for clinical trials, as I said previously. Obviously, at least some of these patients are different colors on this slide, indicating that it might have a different genomic profile. And so a lot of the new drugs that are being approved now are drugs that work on specific mutations in a cancer. And so if you look at the prescribing information for the drug, it says they have to be tested for this specific mutation, and essentially they should only be treated if they had that mutation. Well, same thing when we do investigational studies. We have to screen for those mutations in our patients to see if they're eligible to receive these new drugs. So we're doing that. Now the other thing is, when we do this for research purposes, we could put those data into a database, and we could allow that database to be interrogated by pharmaceutical companies and by other universities without identifiers to the patient, of course, but would allow them to know that we have patients eligible for that study. So think of it this way. If a patient got lung cancer, or a certain type of cancer, and got biopsied but wasn't treated yet, their data went into there, and then the companies or the other universities could help identify that those patients are eligible, and they would contact us, and then we could link them and put them onto the study then. So we talked about the indications for the drugs. Now let's talk a little bit about dose selection for an individual patient. So how do we get rid of drugs? Anyone? Come on, some budding pharmacologists out there? You take a drug, it's in your blood. How does it leave your body? Kidneys. That's an easy way, right? A lot of the new drugs we have, though, aren't really highly eliminated by the kidney. So if it's eliminated by the kidney, we get easy tests for that. We can tell how much to give a patient. But when it's metabolized, it's tougher. So the other area that we have to deal with when we start talking about doses is body size. And you would be surprised how many studies aren't done in this area. We're actually doing a number because we have patients, as I said, we have to deal with an obese population. And you would be surprised at what's not known about the appropriate dosing of drugs. Some drugs we give based on body size. Most of the drugs in cancer we give based on body size, but we don't know sometimes whether or not someone that is morbidly obese, that we should dose them differently than someone's not morbidly obese. Should we use their total body weight? Should we use their ideal body weight? So we're doing research in that area with a number of drugs. Smoking. Smoking affects drug metabolism. So there are drugs on the market and ones investigationally that smoking itself can accelerate a number of processes in our body, and smokers can sometimes need different doses of drugs. One of the drugs that I showed for that EGFR mutation, or erlotinib, we actually, one of my studies at Duke was first to identify that there was an acceleration of metabolism of that drug in smokers. And the company went ahead and did a subsequent study showing that you need to adjust the dose in smokers. Drug interactions, obviously we're combining drugs, and we have to do research in those areas to select the right dose, because sometimes they affect the metabolism of each other. And finally, genomics. Our normal cell genomics can affect the metabolism of drug. So not the tumor genetics now, necessarily, but the normal cell genomics. So I'm just going to skip through this real quickly here. This is just some examples of normal cell genomics. This is a clinical case from a patient when I was at Duke. That was a man that had colorectal cancer, and we were giving him this drug, 5-fluorouracil, and he had really unexpected toxicities the first week. And this is a syndrome that is an indication. Here's how we get rid of the 5-fluorouracil, through this enzyme. And this particular patient had altered copies of that enzyme. Now these are normal things we carry around. Everyone here, their DNA is different, right? And sometimes our drug metabolism genes are different. We never know it until we take a drug. And so there's some drugs that we know, if we have a variation in our enzyme, we're going to dose the drug differently. And that's what happened in him. His actual requirement for the dose is about a dose of 5 compared to a dose of 300 in a normal person. And this just talks more about that. And here's just a couple examples of areas that we're doing research in with other drugs. And this is a drug called cisplatin that we discovered a genetic defect in it that changed the blood concentrations of the drug. But surprisingly, when we looked at those patients that had better survival, or those patients that had this variation, had better survival than those patients that didn't have the variation. And so that actually is leading us to some other studies on the real practical applications of this and how we're going to move forward with it. So finally, I'd like to talk about one other area, because you see it on TV every night if you watch the nightly news, and commercials for immunotherapy, right? And so, gee, let's talk a little bit about what this stuff is and what it means. So this is our normal immune system on this side. We have things called T cells and dendritic cells that try to attack the tumor. They see the tumor as something different than our normal cells, and they're trying to attack it. The problem is our cancer cells sometimes have things on there that protect them from the tumor. They make them invisible. They make them invisible to the immune system, essentially. And so these immunotherapies that you see on TV, what they're doing is they're down here. They're antibodies that are blocking those receptors on the tumors, and that allows the immune system to then attack the tumor. So it's unleashing our normal immune system. So there's a couple of those drugs, and they've made dramatic improvements in some cancers, like lung cancer. But the problem is they're not working in everyone, and we don't know why yet. And that's where personalized medicine comes in. We're trying to explore the genetics of why that's occurring, why we don't have any good predictors of why it's working in one person and not in another person right now. The other side of this, as you're going to see in the near future, is this side of it. We got to soup up the immune system to kill the cancer too. We got one drug that does that now, but you'll see many more drugs coming on the market in the future for this. And we're doing a number of clinical trials in this area, from lung cancer, head and neck cancer, lymphomas, leukemias, myelomas. So we have clinical protocols open. You can look at our website if you're interested in seeing the specific ones for patients to go on these trials. Unfortunately, these drugs are super expensive now too. So maybe we're saving the health system some by putting them on a clinical trial, because the companies are paying for the drugs when we're on a trial. So finally, where are we going to the future with precision medicine? I didn't really talk about our traditional chemotherapy drugs, but hopefully genomics is going to help us dose those drugs better, or select the patients out where they're really needed. We talked a lot about the genetic pathways, and we talked some about immunotherapy. And oftentimes, we're probably going to be combining these treatments, the selective targeted drugs with immunotherapy, plus or minus the traditional ones as we go forward. And where the genetics is going to help us in precision medicine is to look at drug resistance, look at that tumor diversity or heterogeneity, as I called it, the liquid biopsy area, and discovering new targets to be able to explore new drugs. So the final area of this is prevention. As we know, prevention is incredibly important. And catching a cancer early changes the ball game in many patients. Statler's are in the audience here, and they, by their resources of Bonnie's Bus, have screened over 10,000 patients in West Virginia and caught a number of cancers in women that probably would have never gotten a mammogram, most likely saving their lives because they caught them early. But genetics approaches hopefully will do the same down the road here. But there's a number of other successful approaches that we've had in suppressing, we'll call the public enemies of cancer and other things. So any guesses what that is? Any budding virologists in the audience? That's the HPV virus. So what do we get for that? Yeah, so it causes cervical cancer and a few other cancers too, some head and neck cancers. How can we prevent it? Vaccine, right? So we have the HPV vaccine. Doesn't treat once it occurs, but it will prevent it in incredibly efficacy in prevention of cervical cancers. Here's another public enemy. For those of you who are at least over 50 in the audience, Boris and Natasha. Who do we have for curing them? Anyone remember? Yes, moose and squirrel. This one's for Cindy. There's another public enemy. We know we get to cure that. Here is our close number 1, 2 public enemy, tobacco plant. So hopefully, we could talk a lot about strategies for preventing smoking and oral and regular tobacco smoke. But one of the most effective ones is taxation, unfortunately. I don't want to say the word in a political year, but that has shown the most efficacious in reducing smoking rates, and hopefully, I guess that's going to happen in West Virginia this year, at least. I think what's on the table is another $1 in the tax, which we are we have a very low tax right now, and it's probably driving our smoking rate. All right, Dr. Marsh, what is that? Our other public enemy, sugarcane, the sugar. And we know we've talked about a lot of ways of preventing that from occurring, activity, dietary aspects of it. So we have a lot of challenges. We have a lot of opportunities for prevention. We have a lot of opportunities using precision medicine approaches to combat the cancer. I'll leave you with my blatant advertisement here for our Greenbrier Gala for the Cancer Center, and I'll be happy to try to address any questions you have.